Good afternoon, everybody, and I thank Dr. Rohit to have me a part of this course. So we'll discuss something that we do frequently face, and as pediatric ophthalmologists, the pediatric eye exam, we're it's the commonest thing that we'll probably do, and I'll come quickly to some of the challenges. And there are some solutions that I've thought of. There are a lot of other solutions that are there, so we can always discuss them. And we're really happy to know everybody's point of view. And if you guys are doing things differently, I'm sure that we'll be happy to if you can share that with us. So I think the first thing in the pediatric eye exam is the history. And the challenge actually starts right away, because here the informant is important. And very often in our country, the informant may actually be somebody different compared to who is actually staying with the child. So it's very important to try and get information from the person who's taking care of the child. It could be the grandmother, the mother. So that's very, very important. The other is the complaints. So a child can't usually tell the complaints. So the parents will tell the complaints, or the informant will tell the complaints, and they're often incomplete. So it's important that you do some direct questioning. So that's very important. Does the child rub the eyes? Do the eyes get red? Does the child tend to rub one eye more than the other? So some direct questions are very important when you come down to this. And always, you can always ask the child in a local, friendly manner. And a lot of children, even young ones, will be able to give you some idea that they're feeling some pain, some itchiness or the other. So that's a very important thing that you need to look at. Then the duration. So for duration, again, there is often a confusion, and many times they'll not talk about it from birth. They'll say it was noticed later on, things like Duane's retraction syndrome. Parents say, no, it started only at 3 years of age. They probably didn't notice it earlier. So old photographs, go a long way on looking for that. For family history as well, this sibling or who's come in maybe, having a very sort of prominent squint, but the other sibling could not. But, you need to examine, because you'll actually realize that it's probably there. Or likewise for refractive errors as well. So that's important. And treatment history, again, the parents or the informants themselves are the treating people. So one, that they may not be sure on how they're treating, or even if they are, they'll often misreport it. So they'll say, yes, he patches the eye every day, because otherwise they're the ones at fault. And so it's always important to kind of reconfirm that with them. And for treatment history, again, direct questions work well. And always ask two separate informants. That's what I always do when I need to make sure on compliance issues. So remember, history goes a long way for the pediatric eye exam. So in examination, some of these points have already been covered. So in vision, children are not very cooperative. They may be pre-verbal. They cannot read the charts. Even if they can read the charts, their attention span is small. So there are a lot of indirect ways of checking the vision. But most important, one has to be patient. So you have to have patience. In a pediatric eye examination, that's probably one of the most important things. But yes, we've gone through some of these using special charts and sweets. So treats work very well. So reward them if they're telling you, and then this will go a long way actually in the child cooperating with you. Assessment of vision I won't go much into. For refraction, likewise, it's a challenge in children, because they'll often not be cooperative for the autorefractors. That's number one. There'll be a lot of variability in the refraction. You have to do a cycloplegic refraction. They hate cycloplegic refraction, so they don't want to get eye drops put. That in itself is a problem, and you have to make sure that the child actually has had proper cycloplegia before you go ahead and perform the refraction. So these are all aspects, challenges that come around in the form of refraction. And the solutions, of course, lie in the form of, so retinoscopy is a very, very important thing. Of course, the treat always works, so that sweet box should always be with you. You have portable autorefractors. It's not something that we routinely advise or ask you to do. If you do a good retinoscopy, that itself goes a long way. And you must use cycloplegia, and as has already been discussed. For the head posture and external adnexa, again, cooperation is sometimes an issue. You aren't sure if the child is actually being able to hold the neck as well properly, or if that's for a very young child. But older children, they'll often get conscious. So you must look at them when they're not, when they're not conscious of the fact, or when they're walking into your room, or if you're talking to the parents. From the corner of your eye, have a look at what posture the child is keeping, and that's very, very important. Likewise, for external examinations, you often have to do a distant examination and use indirect clues. If you can't sometimes evert the eyelids to look for papillae, but the condition of the conjunctiva and the cornea can give you a hint that he's having a severe VKC. Ocular alignment and movements, again, some of this has already been discussed by Professor Rohit earlier. Again, children are uncooperative, and you'll often have variability in findings here, particularly when you're looking at ocular movements. Again, you can use Bruckner's reflex, you can use corneal reflection tests. And for ocular movements, you can use toys in very younger children, and you can patch one of the eyes, if the child doesn't allow you to cover the eye physically. So you can patch one of the eyes and then check them individually, alternately. So that's important. For cataract examination, or essentially the lens examination, the challenge again is that they're quite uncooperative. They'll not sit on the slit lamp, the younger ones particularly. So here the distant direct ophthalmoscopy works very well. You have portable slit lamps. I've used a few, sometimes cumbersome, but yes, I mean, they can be if you want to define the type of cataract that's there. And but more, sometimes you have to do an examination under anesthesia in order to be able to pick up what's there. Fundus evaluation, somewhat easier, but still children are uncooperative. They'll again require dilation, and sometimes they're too young for the regular eye drops, so you have to dilute the eye drops. So that's important. You have to be able to do a good indirect ophthalmoscopy, and that's very important as well. So small children like ROP, you can double dilute the eye drops, and sometimes you need to make the child comfortable and use different devices. So here I'm using a portable fundus camera in a child who's having a lot of nystagmus, so one click and I'm able to catch it. But again, an indirect would have done exactly the same job for me. Intraocular pressure, again, a difficult thing to do in young children. The question we need to ask ourselves, is IOP really necessary? So in a lot of the times in the very young children, you can actually get to know if there's glaucoma or the IOP is high by looking at the cornea, the condition of the limbus, and other things. So, you may not actually require the absolute value, but if you do, then there are alternative you can do a non-contact tonometry in some children who can sit down and cooperate. At least one eye you can get it before they realize, or use a Paracan local anesthesia topical eye drops. You can do it with a Perkins, with a tonopen or an eye care. But sometimes you have to do an examination under anesthesia, particularly when you're taking therapeutic decisions. And IOP becomes important if the child is being treated with steroids for something else, like a nephrotic syndrome. You do want to make sure that there's no steroid response. Stereoacuity, again, a little bit of a niche thing here, but children are uncooperative, so you can either use this, and I've seen the Frisbee-Davis distance. Even very young children, they understand and they're fairly okay to cooperate as long as you make sure they hold their head straight. And you can use some tests like this Lange test here. The two-pencil test works very well for a gross stereopsis. Again, you don't necessarily require this in all patients. There are a lot of other challenges which continue to remain, like the gonioscopy, again, would not be possible very easily. Color vision, children will not cooperate. You're not sure if they're actually having color blindness, or they're not cooperative with you. Similarly, for other investigations like perimetry and all, so that's another thing. Confrontation perimetry works well. Otherwise, Goldman applanation tonometry is difficult to do. So, some of these things are there, and of course, I'm sure we'd like to know from the dais as well what their thoughts are. Thank you.